هنأناونس عن الوينر في الجائزة بتاعت دكتور طارق الله يرحمه. يعني قبل ما نقول اسم، أولا بحب أشكر أولادنا اللي ساهموا في المسابقة. هم كانوا 2 متسابقين، بقول لهم انتوا الاثنين كنتوا كويسين، والغرض من المسابقات دي كلها ان احنا كلنا بنتعلم من بعض وبنفيد بعض. فان كان حد اتقال له ملاحظات او فده شيء طبيعي. ده دور المسابقات يعني، او دور الكومبيتيشنز. دي حاجه. الحاجه الثانيه برضك بكرر شكري لاخويا الدكتور ايمن فخري على المسابقات اللي بيعملها في ذكرى اساتذتنا واخواتنا الراحلين، سواء الاستاذ وعمنا وتاج راسنا الدكتور عادل الهامي، او اخونا الحبيب الله يرحمه الدكتور طارق رضوان. واحنا امبارح الحقيقه يعني قرينا الفاتحه على روحهم اجمعين، واعتقد ان هم يستحقوا ان احنا نقرا الفاتحه مره ثانيه على روحهم وارواح امتنا اجمعين. فالفاتحه لروحهم وارواح امتنا. غير الموضوع الاثنين التو كومبيتيتورز بتوع امبارح كانوا الاثنين كويسين، لكن في النهايه التشوز جوز تو وان. الوينر هو الدكتور اسامه حسن. هو في مورية خاصه بالقوات المسلحه، وهيستلمها زميله مينا.
Thank you, Professor Ali Murad. Now I will ask the judges to go and take their places. Please, Professor Ayman Salim, Professor Mustafa Sulaiman, Professor Ahmed Abdel-Sattar, Professor Nasser Saeed, and from Bolivia, I like to introduce my dear friend Luis Arias, the president of Pan American Society of Philology, and the famous vascular surgeon. Please take your seats and be ready for the challenge. Before we'll meet the competitors, Professor Nasser will give a few words about the late Professor Adel Ilham.
دي مفاجأة من الدكتور أيمن. I'm not ready to talk to give a long talk about Dr. Adel Ilhami. So let me speak with Arabic. Try to effort with us teaching and learning us many tips and tricks in vascular surgery. الحقيقة الدكتور عادل excuse me, Dr. Luis, I will speak Arabic a bit to be more clear about Dr. Adel Ilhami. He's our big boss. So الحقيقة يعني أنا بدأت 89 في الفاسكولار في المعادي، كان الدكتور عادل رئيس القسم. من الوقت ده لحد النهارده احنا يعني اتعلمنا منه الكتير، وما زلنا نفتكر. الحقيقه الدكتور عادل كان فضله علينا كلنا، واسم الاوعيه وايفن حتى في مستشفى المعادي كان كل الناس بتحمل له ذكرى طيبه. الدكتور عادل قصصه كتير قوي من ناحيتنا. هو كان تقريبا شبه متفرغ للشغل في المعادي بصفة خاصة وفي القوات المسلحة بصفة عامة. اتعلمنا منه ان مفيش حاجة، البرايفت ده كان بالنسبة له آخر حاجة، وعشان كده خدنا فرصه كبيره قوي ان احنا نجوينت الدكتور عادل في كل الامرجنسي والالكتيف. يعني الوحيد تقريبا حتى كان في رتبه اللواء، وكان راجل كبير يعني في اي وقت يجي بالليل بالنهار. فدي كانت حاجه كويسه. ولما الجونيور ستاف او الميدل جريد دايما يبقوا ان كونتاكت مع البيج بوس، فكانت دي فايده كبيره قوي لينا. الدكتور عادل الحقيقه اعتقد ان معظمنا ومعظم الفاسكولار سيرجن اتعاملوا معاه على المستوى الشخصي. هو راجل دمس الخلق، كوبراتيف الحقيقه يعني. ولو قعدنا هناخد وقت طويل قوي نتكلم على امجاده معانا وفضله علينا. احنا طبعا بنشكر الدكتور ايمن لانه هو الحقيقه اللي اول واحد فكر في دكتور عادل الهامي اووردز، ودي حاجه كويسه نفتكره بيها ونرد له الجميل. واحنا بصدد النهارده اختيار افضل برزنتيشن بالنسبه للمسابقه دي. شكرا دكتور ايمن، وشكرا على التدبيسه دي. شكرا.
The competition or the award, it's called Adel Ilham Award for the best research in vascular surgery for fellows. We ask all fellows around the world to submit their abstract, including a case series, not a case record, and we'll give a good reviewing by the scientific committee. This year we had 15 abstracts from the whole world. The scientific committee chose 4 abstracts. They will run the competition today. For the fairness, all presentations will play it in a recorded video, and each fellow will be ready to answer questions from the committee. At the end, the committee kindly will choose the best, and the man or the lady, because we have a lady, the best fellow that can be awarded. We have 4 competitors: Maria from Russia, Shavkat from Uzbekistan, and 2 Egyptian guys, Mina and Muhammad Goma. Yes? Mina. Yes, Mina.
The 4 around the grades of the marks. Then we divide
50. 10 for each category. Okay, now we'll ask Maria to be ready, and we'll run the video for Maria.
Dear ladies and gentlemen, thank you so much for the opportunity to introduce you the results of our study. There is no disclosure. The aim of our study is to validate the Caprini score in patients undergoing varicose vein surgery, especially in the vascular procedures, and to identify individuals at the elevated risk of postoperative PT who will benefit from prophylactic anticoagulation. This is analysis of ongoing registry study CAPSIVs, which includes patients who underwent treatment for varicose veins for any intervention and who is followed up for 28 days with ultrasound performed between 2 and 4 weeks to catch any kind of DVT, especially asymptomatic DVT and intravenous heat-induced thrombosis. This analysis was performed in February 2022 with a number of records 1878. You can find here demographical characteristic of the patients. The Caprini score ranged between 1 and 12 with a mean of 4. And the most important risk factors of the Caprini score you can find here in presented diagram. The VT prophylaxis consists of elastic compression that was used almost for all of the patients, and pharmacological prophylaxis that was used just for 20% of the patients. NVT event was detected for 63 patients, that is 3.4%, NEDVT in 39 patients, and HIT in 28 patients. The location of DVT mostly was presented in cuff muscle veins, 1 case in peroneal veins, 1 in femoral vein, and 1 in femoral and iliac vein. Bleeding was detected in 2 cases and were represented by clinical elements of uterine bleeding at the top of the prophylactic bleeding docs. There was a significant correlation between the Caprini score and incidence of VT, but we couldn't identify the cutoff of which specificity and sensitivity could predict the development of postoperative VT. Here you can find the predictors for VT. We found in the single factor regression analysis that chemoprophylaxis type and duration of hemoprophylaxis was a risk factor. And we decided to make a separate analysis for chemoprophylaxis as a predictor for VT. Here you can see that 1 day of hemoprophylaxis is not enough, but also prolonged hemoprophylaxis is not always working in positive side because of the individual history. Also, there was analysis between Caprini score in patients who did not receive anticoagulation, and we found significant correlation and significant predictability without any satisfied cutoff which could predict the development of postoperative DVT. Caprini score became a significant predictor in the single factor and multiple factor regression analysis. And together with the removing of the tributaries and removing of the perforating veins were the more important and significant risk factor for postoperative VT. And here you can see the diagram with separating patients for risk groups and relevant prophylaxis. Low risk, no routine chemoprophylaxis, moderate risk prophylaxis 7 and more may be suggested, high risk from 7 to 30 days, and patients with individual history of VT, chemoprophylaxis for 30 days and more. Conclusion. The incidence of postoperative VT after modern vein surgery is 3.4%. Is predominantly represented by asymptomatic DVT and a HIT. The incidence of symptomatic VT at 28 days after modern vein surgery is 0.5%. Caprini score demonstrates a significant correlation with the risk of postoperative VT, and according to the group of the Caprini score, prophylaxis anticoagulation for 7 days and more may be suggested for individuals with a Caprini score for 7 to 10. From 7 to 30 days for Caprini score 11 and more, and prophylaxis for 30 days and more for patients with an individual history of VTE. Thank you for your attention.
Okay, Maria, are you here?
Hello, yes, I'm here. Hello, dear colleagues. Nice to meet you.
Okay, now be ready for the questions from the committee.
Thank you very much, Maria.
Yeah.
Спасибо. It was a great presentation because the importance of the prospective register of the Caprini score, it is very helpful in the actual medicine. I just want to make you a question. Why is the reason that you find this project? Tell me, what's the take you make this decision to do this project?
Sorry, could you please repeat the second part?
Why approach this topic?
Why we approach this topic?
Yes, the reason.
This is really important right now. Is going in phlebology complications like hits and deep vein thrombosis complications after intravenous laser ablation, for example, or methodical fast valve. And we decided to validate Caprini score because it's really interesting to predict before, like to know how long we will treat patient with the anticoagulants, like do the patient need anticoagulants or no. So, and we just found really interesting and important the validation of this Caprini score.
Great. Do you know in person Dr. Caprini?
Yes.
Yeah, I think he's very proud of you. Congratulations.
Yeah.
I have a question for her. No doubt that Caprini score is very important for any surgical patient. But have you found any relation between EHIT and the score of the patient? Because EHIT, I think it can occur in any patient, no matter what's the score of Caprini is.
Mm-hmm.
So have you found any relation between this?
With EHITs also yes, but it's also included with VT and EHITs. Like all of the complications was 3.4% after laser ablations. But we will do in next our clinical analysis, statistical analysis. Sorry, we will do directly to EHITs the analysis. Here is more for DVT veins. This one was counting.
No more questions?
Okay. Do you apply the Caprini score in your practice?
Sorry?
Do you apply the score now in the routine practice? Or
do I use it during routine practice?
Yes.
Yes.
Practice.
With this research, we started like most doctors of our
outside the research. Outside the research,
yes.
So, yes. Is it applied in your practice, clinical practice?
Yeah.
Yes.
It's really practical here, and in some clinics, doctors also used it without research, and of course with the research.
Okay. Thank you, Maria, for your nice presentation. I'm actually wonder about your skill in presentation. My question for you, how far you believe in Caprini score? I mean, in your practice, this is the only score you depend on or others score? And you mainly depend on the Caprini score or your background experience in taking decision?
Okay, so
you got my point?
Sorry?
You got my point?
My
question is clear for you?
Yes. So how we use like the practical Caprini score with the
Maria, Professor Nasser is asking you use Caprini score. You don't use any scores else?
In this CAPSIFs, we using...
No. In clinical practice.
In clinical practice, yeah, we're using VCSS sometimes. And also when we need to check the phlebotomies, and some of the decisions with the patients of quality of life before treatment and after treatment, we are using CVIC score, CVIC 20.
Okay, thank you.
SIP and so on.
Thank you, Maria.
Welcome. Thank you.
Thank you.
Okay, Maria, thank you. And be in contact to know what's your position. By the way, Maria won the prize last year. Now I would like to introduce second competitors, Dr. Mina Max. Yes, they will play the video, and please come to the podium to answer questions.
Dear colleague, my name is Mina Nadi Max. I want to start my presentation with a question. If you see this anatomical view, which vein will choose to do a fistula? Is it cephalic vein or antecubital vein, which supply both cephalic and basilic veins? Please remember this slide for the two ways. And to answer the question, we have two main factors. The first, what about the maturation of the fistula? And the second, what the incidence of development of ischemic state syndrome. And I will focus on this point in my presentation. So it is a comparative study between the incidence of ischemic state syndrome after brachio-antecubital fistula versus the incidence of ischemic state syndrome after brachiocephalic or brachiobasilic fistula. We have many patterns of superficial veins in cubital fossa, but type 1 and type 2, it is the most common patterns, and in both antecubital vein supply cephalic and basilic veins. We have about 70 to 80% of male and female who had type 1 and type 2 variations of superficial veins. Common complication of the fistula: access failure, bleeding, infection, aneurysms, seroma, venous hypertension, ischemic state syndrome, and cardiovascular complication. Ischemia, it is a reduction of the blood flow distal to the fistula. About 80% of the cases has a reduction in distal blood flow. Only 10% of the cases has mild symptoms, which is resolved in few weeks. Only 1 to 2% have a significant ischemia. Please remember, no test can predict development of ischemic state syndrome. Grades of ischemia: grade 1, grade 0, no symptoms; grade 1, mild; grade 2, moderate; grade 3, severe. We have a wide range of signs and symptoms according to the severity of the ischemia. Diagnosis based on physical examination. Improvement of the symptoms with access compression confirms the diagnosis. Duplex study useful for detection of the cause of the ischemia and planning of the treatment. This comparative study, a total 70 patients divided into groups: Group A, brachio-antecubital fistula; Group B, brachiocephalic or brachiobasilic fistula. All patients had diabetes, hypertension, under regular hemodialysis. Duplex assessment pre-operatively: cephalic vein and basilic vein diameter 2 to 3 millimeter, brachial arch diameter more than 1.6 millimeter, and a smooth diameter ratio not more than 1. Assessment criteria: third over the veins, palpable distal pulses, signs of ischemia, duplex study, follow up after 2 weeks, 3 months, 6 months, and 1 year. In brief, our results are: at 2 weeks, 1 patient from Group A and 1 patient from Group B has mild ischemia, which is resolved spontaneously in few weeks. After 3 months, 2 patients from Group A has a sign has ischemic symptoms. 1 of them has severe symptoms, and I will discuss it later on. After 6 months, 1 patient from Group A and 2 patients from Group B has mild ischemia. After 1 year, no any new cases. Duplex study, normal average volume flow except in 1. This is a final results. 8.5% from Group A and the same from Group B has mild ischemia. 2.5% from the Group B has a severe ischemia. This is a case study. male patient, 48 years old, diabetic hypertension, under regular hemodialysis, complex study preoperatively according to our criteria. Patient underwent left brachial antecubital arteriovenous fist. Follow up after 2 weeks, no signs of ischemia. After 3 months, patient has grade 3 ischemia with little finger. We chose to ligate basilic vein, but no any improvement of the symptoms. Ligation of the cephalic vein with amputation of the little finger. Ischemic symptoms disappear with distal pulses. This before and after. Now we are going to finish our study, and I hope it is clear that no difference between 2 ways to choose cephalic vein and or antecubital vein, which supply both cephalic and basilic, are the same. So 2 ways become 1 way. My home message: brachial antecubital fistula don't increase incidence of ischemic stent syndrome. About 10% of the case developed mild ischemic symptoms. Most of them resolved in few weeks. Only 2% of the case might have significant ischemia diagnosed based on physical examinations. Improvement with access compression confirms that diagnosis. So thank you for your attention.
Thanks. Hello. It's really very, very interesting, this abstract, this project. Young fellows, new ideas, new studies. I just want to congratulate you. No questions from me. Thank you.
Thank you, Dr. Max. I just have a little questions for you. Do you have any clue during fistula, antecubital fistula, that this patient may high incidence of getting ischemia intraoperative, and you can change your mind? I mean, do you have any means to discover after finishing fistula, during the fistula, this patient may have ischemia?
This patient that developed severe ischemia, about 1 month, no any signs of ischemia.
I mean, in general.
In general,
after first antecubital fistula,
all patients seemed normal. No any signs of ischemia after fistula. Even they have a distal pulse.
Check the distal pulse.
After the operation,
during the operation.
Yes.
After you finish.
Yes.
And if still the radial pulse is,
yes,
it's normal, you can close the skin and even resolution. If not, when the radial pulse disappear or weak, so you can change your mind.
In this study, all patients that yes.
Okay, thank you.
May I ask you about your hypothesis in this research? What is the question you need to answer, and why you do this research?
Okay.
What is the difference between antecubital and cephalic and basilic vein in anastomosis you suspect works?
We focus. We have many options when we say the antecubital vein, which supply both cephalic and basilic veins, and we must to choose who we will do fistula on cephalic vein only or cephalic and basilic. The advantage to do on cephalic and basilic vein, in the future, if the cephalic vein is occluded, we had already fistula with maturation of the basilic vein, so we can do superficialization as soon.
Yes. Basically, we have to assess the veins and the arteries of the patient pre-operative.
Yes.
Did you apply any tests to check the hand ischemia may be supplied by single artery radial only or ulnar only by applying Allen's test. I think that ischemic seal syndrome affecting patient who has already ischemic hands.
Yes.
Did you apply any test like this?
In my study, I don't studying steel ischemic syndrome as a title. I only test what about incidence of steel ischemic syndrome in cephalic when I do fistula in cephalic vein only or in antecubital vein. I don't study what is the cause of ischemic steel syndrome by title. Okay.
Okay, I mean, the last question for me. You did your study in two groups, A and B, as you said. On what basis you choose your patients to go for A or B? Is it on anatomical basis or?
Anatomical.
How you choose? And if the patient has antecubital vein, we put him in the group A or group B?
Antecubital vein supply both cephalic and basilic. Group A.
Group A.
Yes.
So it is on anatomical basis.
Yes.
So anatomically wise, have you tested the arterial tree after the brachial? I mean the ulnar and radial regarding atherosclerosis or narrowing or stenosis or any disease, because it might affect your results.
Yes, affect the result of causes of ischemic steel syndrome at the general, but not affect which vein I want to choose.
I mean, if you have disease, the radial or ulnar artery, and you did it this patient as antecubital vein anastomosis, and you develop the steel syndrome. So you will refer this to your operation or the arterial disease itself.
Arterial disease.
So you cannot compare at this point between antecubital and cephalic or basilic.
Then right? Okay, I got your opinion.
Yes, radial pulse does not exclude.
Maybe the only artery supplying the hand. Usually we validate the radial artery, like
yes.
We cannot validate the
No, I mean the duplex examination for the arteries before the intervention.
It is an important point to do examination of the arteries before the operation.
Yes.
If we have two cases with the same diameters or the same blood flow in brachial artery before the operation, if we did a fistula on cephalic vein only in one case, and in the second case we do on antecubital vein, the incidence of development of ischemic steel syndrome in both are the same.
You don't want my points. Anyhow, no. You do your intervention, your anastomosis end to side or end to end?
End to side.
Sorry, your side to side.
Side to side with ligation of the distal side of the vein.
For both groups?
For both groups.
So how to judge for the basilic vein flow if you ligate?
I didn't ligate basilic. Distal.
Yes.
Vein.
Yes,
you know any flow in forearm.
I'm talking about the vein. You do it side to side or end to side.
Side to side.
Side to side in all cases.
In all cases.
Even if you do cephalic or basilic.
Cephalic vein side to side and then ligate distal.
So that's end to side.
Okay.
So when you do the antecubital vein anastomosis, you do it side to side or end to side.
First, we do the side to side, and then we like this
end side.
End side. Okay.
In both groups.
In both groups.
So you cannot wait for the flow in the basilic because you ligated the antecubital vein.
cubital. In case of antecubital, you ligate distal. How? Anastomosing with the antecubital. Yes. And
then you will ligate distal to the anastomosis.
هو انا صح ايوه احنا في كفالك والبازيليك.
Okay. All your patients were diabetic?
Diabetic, hypertensive.
All diabetic.
If you ligate the antecubital vein distally, so
how can you find 70 patients diabetic?
Yeah, this is a very good question. You are very lucky, man. You have 100% diabetic people. How you find all your patients diabetic? You make a contest or?
By history, all patients had a diabetes.
No, how you find all for make a group? 70 diabetic patients.
This study for 2 years in our hospital, Kubra Rubba.
And
flow is much.
It's okay. Yeah, we are ready.
بص بترسم الانستموزس عشان توريه للدكتور مصطفى لان في نقطه في ميسنج يعني بس عاوزين لان هو قال الدكتور لو ربطت الدكتور مصطفى قصده ان ما فيش فلو هيروح للبازيليك لكن انت ما بتربطوش.
لا ديستال للانستموزس.
ايوه ديستال اللي نازل لتحت مش كده بس هو الدكتور مصطفى مش مقتنع.
Thank you, Mina.
He ligate here and here. That's simple. بس اللي نازل على الهام لكن هو بيليف.
Okay, I think we have to go to the VAR. Now, may I call the third competitor, Dr. Muhammad Goma. Please play the video.
Bismillah ar-Rahman ar-Rahim. My abstract about role of the endovascular intervention in the treatment of primary varicocele. My name is Dr. Muhammad Juma Barros, Vascular Surgery Department at Azhar University. At first, we speak about varicocele, which are dilated tortuous veins of the pambiliform plexus. This veins drains into the antenosmatic vein, which is called the gonadal vein. Diagnosis of varicocele by history and physical examination, followed by imaging study, Doppler ultrasound. Indication for treatment of primary varicocele include infertility and pain. The aim of my work is to assessment result of endovascular intervention in the treatment of primary varicocele, as regards its complication, its efficiency, its occurrence rate, to choose the best method for treatment of primary varicocele with least complication and the higher successful rate. Methods for treatment of primary varicocele include laparoscopic, surgical, and endovascular. We speak about endovascular, which is limited to use of local anesthesia and good sterilization. For vascular access, we do vascular access using 6 French vascular sheaths. For left side varicocele, the most common access is the right common femoral vein. And for right side varicocele, the most common access is the right internal jugular vein. This picture shows that the axis of cannulations of the left rheumatic vein from the right femoral axis. Followed by insert of 0.035 inch hydrophilic wire, followed by 4 to 5 French diagnostic caster, and the caster tip is placed at the junction between the left rheumatic vein and the pambiliform plexus, guided by fluoroscope. How to choose my embolic agent? Choose embolic agent depending on the size of diameter of the gonadal vein. We can choose solid agent as coil in diameter high, and if in low diameter, we can choose liquid embolic agent only. In this picture, we show that cannulations of the left rheumatic vein from the right femoral axis, and in picture B, we show that phenography of left gonadal vein. In picture C, we show that phenography of left gonadal vein with discs and collaterals between right and left gonadal. In picture E, we show that coiling of in picture D, which is coiling of left rheumatic vein. In picture E, we show that the coiling followed by embolization followed by coiling, which is called sandwich technique. In picture F, we show that complete obstruction of left gonadal vein after coiling. Post-intervention care, after removal of the gastrin sheet, compression of the intersite for about 2 to 3 minutes, followed by patient follow-up for about 2 to 3 hours after intervention before being discharged home. Our results show that about 20% of the patients show post-intervention normal duplex, and about 86.7% of the patients show improvement of semen analysis. This present study confirms that the endovascular intervention in the treatment of primary varicocele is best method for treatment with low complication and higher successful rate, with avoiding use of general anesthesia and rapid recovery of the patient. In this picture, we show that the axis of left spermatic vein from the right femoral axis. In this picture, we show that axis of left gonadal vein and membraniform plexus from the right femoral axis. In this picture, show axis from the right jugular axis, and this picture shows that axis from the right jugular. This picture show phenography of left spermatic vein. This picture show phenography of the cystis and the membraniform plexus, and this picture show insert of coil. This picture shows that after coiling and take phonography, we show after embolization and take phonography, we show complete obstruction of left spermatic vein. This picture we show that catheter tip is placed as a junction between the internal spermatic vein and the membraniform plexus. In this picture, we show embolization during embolization of gonadal vein. In this picture, we show after embolization with complete obstruction of left spermatic vein. Thank you.
Did you do as a routine in treatment for infertility or for pelvic congestion?
We in Azhar Hospital we do that twice, but my abstract is about varicocele only.
For varicocele
only.
For infertility. For infertility.
Infertility and pain.
Okay. And the results assessed by the increasing the semen analysis count and mortality.
Duplex guided and semen analysis. Duplex guided after 3 months and semen analysis.
Duplex assessment.
Duplex assessment.
Yes.
Thank you, Dr. Mohammed.
Thanks.
You said in your presentation that this intervention is safe with local anesthesia and you avoid the complications of surgery. But this carries also risk of complications.
Yes.
You have puncture, you have contrast material, you have embolizing material. So what's the instance of your complications?
We show only one case with the difficult access of gonadal, with no complication of other cases. But complication may occur hematoma or infection outside of puncture, ممكن embolization للrenal أو arrhythmia في الهارت, but we show no complication.
Okay.
Thank you. How did you choose your embolic agent to embolize the renal? On which base, what base you choose your embolic agent?
Dependable on the diameter of gonadal vein by duplex ultrasound. In diameter more than 8, we do coiling. And in more than, we can do sandwich technique, which is coiling followed by embolization followed by coiling. But in low diameter less than 8, we do embolization only.
What embolization? This is
polydecanol. We choose polydecanol.
Polydecanol?
Yes.
Foam therapy?
Yes.
You embolize by foam, you used it?
Yes. During the caster.
عن طريق كاستر فوم ثيرابي يعني.
Yes. We do the caster.
فوم سكيو ثيرابي.
Yes.
ما استعملش بارتكلز ولا حاجه مثلا؟
لا ما استخدمناش اي حاجه غير امبولايزيشن وكويل بس.
Think in the large gonadal vein, there is any room for vascular plug instead of using coils plus do you try any vascular plug to include the large gonadal vein or just stick to the coil?
we just use of coil only بس but glue can be used يعني but our abstract is about coiling and embolization only.
استعملت كم مرة كويل وكم مرة استعملت فوم؟
embolization only
your series.
embolization only عملناه في حوالي 20 كيس في حوالي 20 حالة but coiling في 10 حالات بس.
في 10 حالات. هو أرخص.
embolization.
Yes.
Thank you.
Just one more. This is not too technical, but how often you find varicocele cases here in your country?
In our clinic?
In general. In general, in your country here.
At first اول ما بدانا نشتغل ما كانش في حالات تجينا بس بعد later on okay at first we don't find the case but later on we find multiple case.
You don't have any percentage?
About 10% of the general population. Yes.
For every 1,000 patients, how many people you believe here in Egypt have this pathology?
All of our cases, except I don't understand the question.
I like to ask you about percentage of the quantity of patients you believe have this pathology, varicocele. From every 1,000 or 10,000, how many patients?
About 10% of patient.
In general in Egypt.
In general Egypt, 10% of people. About 10% من.
You're asking him about in Egypt or all over the world? In Egypt.
In Egypt.
We don't have the statistics.
يعني no papers about that in Egypt, but mostly papers speak about all the world. Yes, thanks.
Thanks.
I think it's all three presentations. Yes. No, the fourth one is not. We have only the young fellows for the best abstract, Maria Saudina from Russia, Dr. Menamat for Egypt, and Dr. Mohamed Goma from Egypt. I think all three cases was very nice, good presentations. I think we have to take a couple of minutes to decide.
Okay, please take your time, and Dr. Nasser will collect your opinions and will declare the winner by the end of the day today. Best of luck for the three competitors. Thank you, and may I ask Professor Ahmad Taha, Professor Hussam Al-Wakil, Professor Hussam Tawfiq. Please take your places as chairperson for the next session. Next session is a very important session discussing we can go to the VAR again. Yes. Now it's time to start the fourth session. It's zone care session, and I will leave the mic for Professor Ahmad Taha.
Good afternoon. A really great session about wound care management.
and I'm going to chair this session together with my dear colleague, Professor Dr. Hussam Tawfiq. Dr. Hussam Tawfiq is a professor of vascular surgery at the Gazette University. And we're going to start with the first lecture is given by Dr. Munir Nazal from the United States. Dr. Munir Nazal is going to talk about strategy and policy of wound management, wound care management. Dr. Nazal.
Thank you very much, Dr. Taha, and thank you, Ayman. Thank you for the invitation. I enjoyed some of the lecture you have. I know wound care is not vascular, but at the same time, I can tell you wound care is really vascular, and every vascular surgeon has to have a good knowledge about wound care in general. But why we have a problem with wound care is what I'm going to talk about. First of all, I have no...
Good morning.
Sorry. I have nothing to disclose related to this lecture. You know, we all know what are wounds. I'm not going to define them, but generally, wounds and non-healing ulcers are very common. In the United States, we are talking about 20 billion a year. Yes, with a V, not M. This is an old figure. We are talking about now 26, and in 5 years, close to 30 billion a year because of the aging population. The population here is aging, a lot of them in the nursing homes, and the care there is not the best when it comes to wound care. Chronic ulcer, as we define it, or it was defined for us, something that is not healing over a 6 weeks period the way it should heal. Doesn't have to close in 6 weeks, but it should follow a trajectory, that trajectory leading to healing. And in 6 weeks, for example, it should be like 40 to 50% at least healed. About 15% of the United States population will have a twin stage, especially the older population, will have a diabetic ulcer or a chronic ulcer or any type of ulcer. And almost every year, about 2 to 3 million Americans will have an ulcer. I'm sorry, I'm talking about Americans because this is most of the information I got here. I tried to get something about the Middle East, but unfortunately, we don't have good data about the Middle East. We have some data, not good data. So how do we define wound, abnormal wound? It is either a wound that fails to heal or overheals. That is the simplicity of the definition. And a chronic wound is an acute wound with an impediment. And that impediment sometimes defined as the treating physician. So one of the impediment for healing are the treating physicians actually. And that's not what I said, that's what other people said. There are factors we know that interferes with wound healing. You know all this. But if you look at those factors, it's not only revascularization. It's a lot of factors interfering with wound healing. So it is multifactorial at least. You know very well, like I do, there are different types of ulcers. Not all ulcers are made the same. There are vascular, neuropathic, there are metabolic, hematological, traumatic, tumors, infections, fat necrosis, vasculitis, pyoderma, and much more, like sometimes hypertension, certain types of diabetes, not neuropathic. So a lot of causes for wound healing, for wound ulcers in general. So there are many types, different types. So that tells you one type of treatment is not going to cut it. It's actually multifactorial and different types. But there are guidelines. The guidelines for a good wound healing, good blood flow, no hypotension, smoking is a problem, sugar is a problem, temperature is a problem, oxygenation in general is a problem, debridement, devitalized tissues is very essential, and minimize the presence of hematomas, seromas if you do a surgical technique. So there are principles of management that you know very well, from treating infection down to improving the condition of the wound so that it can heal, and that includes bed preparation, topical application, callus removal. The European Wound Medical Association came with a statement in 2014 and reinforced in 2015 that managing wounds occurs only as a team. So this is the first principle. The first principle, wound management is not one specialty. It is management as a team. It should be patient-focused. Referral mechanism is established for needed services, and it should be as early as possible in some cases, like infectious disease. Aggregation of assessment data to form a single plan for each type, and you need to follow that plan. That's what we call guidelines. And appropriate remuneration systems to help the treatment and the treating groups, and the healthcare system sensitive to team models. Disrupted teams will hurt only patients. This is the problem. If you look at the different types, that there are nursing dealing with it, surgeons dealing with it, physicians, podiatrists, etc., etc. Usually when I get that patient, they send it to me either a wound specialist, then I look at the patient altogether. Or sometimes it comes from a wound specialist to me as a vascular specialist. Then I look at the wound only, I look at the blood flow. And there is a difference between that. So if I look at the patient multi-specialist, which means I represent all the specialties in my wound center, then I look at everything. I start with the nursing part, is the patient well served in his home, in his nursing home. I look at actually his nutrition, etc., until I reach the blood flow, which is the last thing sometimes I look at. But if they send it to me to check his vascular blood flow, I just take general exam and then I focus on the blood flow. That's the difference between single specialty and multi-specialty. What about guidelines? Guidelines are made to guide rather than to strictly follow, but they are not made to be avoided. Usually guidelines are made over a lot of literature review. For example, if the patient comes with an ulcer, you need to check the blood flow. You cannot ignore that if you are not a vascular surgeon saying, I'm not supposed to check the blood flow. The guidelines also says you have to debride the wound, remove the infection, get rid of the inflammation. You make sure the moisture is balanced and make sure the epithelial edges are advanced. So this is what we call the time. There are so many acronyms. Follow any acronym you want, but at the end, they are all the same almost. This is what we call the time acronym. And there are different stages for the ambulatory care, from physical exam to surgical procedure, minor and larger procedure. And the last one is to make sure the patient is well served at home or in the nursing home or in the senior citizen home, wherever the patient is going. But whose job to make sure of that? If the patient is sent to me, do the vascular and tell him goodbye, the patient will come back. The ulcer is not going to heal. So the multi-specialty approach, which is principle, the first principle we talked about, somebody has to champion that management. The champion can be a physician, can be an advanced nurse practitioner, or a physician assistant, can be a nurse. Somebody who will make sure every specialty took care of their job. This is principle number 2. You need to have a champion for wound management. The early treatment is essential, especially with infections. If you delay treatment with infection, revascularization, you increase the chance of amputation in those patients. The treatment should be patient-centered. This is principle or strategy number 3. The treatment should be patient-centered. What does that mean? Most of the time, the patient cannot walk. You are offloading them. The patient has difficult social support. Patient doesn't have money in many situations. This is where the patient-centered is, deal with all his care in a patient coordination. Referral is very important. Vascular, orthopedic, podiatrist, orthotist, and wherever it is needed, an early referral to ID. You need to make sure everything is done properly for that patient as a patient champion or as a physician champion or a nurse champion. From offloading, revascularization, compression, dressing, care coordination, infection control, or This is not the job of each specialty. This is the job of the champion. The dressing, unfortunately, they are becoming very expensive. For example, there are 82 tissue therapy. They are ranging from $200 to $6,000, some of them. So you cannot go apply the $6,000 on an infected wound and you think this is going to work. You have to follow the guidelines, and when it is time to apply them to help the healing, you apply them. At the same time, the patient champion or the wound champion should make sure that this patient is not served by a high ticket. The lowest possible money to help healing should be applied to that patient. After each stage of management, principle number 3 is to evaluate the patient after each stage. For example, after diagnosis, you need to do what is the necessity decision and adds on reviews, goal achievement. So after each stage, you need to make sure you have served the patient in a way, don't cost him a lot of money, better healing, and less stress for them. Offloading, none of the physicians, other than those specialists in offloading, will know all those boots. I know some of them, the ones I use all the time. What I don't know, I get an orthotist to my clinic, and I give him the patient, tell him, provide the best treatment for this patient, please, and let me know how much it will cost. If it is very expensive, the patient cannot afford it, then in that case, we'll go to the lower cost. Oxygenation, you need not to discard the effect of oxygenation on healing some wounds, like radiation wounds, osteomyelitis chronic, diabetic ulcers that are stages 3 and above. So you have to know when to use hyperbaric. And again, it can be multi-chamber, can be single chamber, and you have to make sure that the wound champion is organizing and reminding the physician, telling them, do you think this patient needs hyperbaric treatment? Again, it is multifactorial, as we said. There are myths that we all follow, and they are not true. First of all, wet to dry is a good treatment. Wet to dry is only there to serve the treating physician who doesn't know. Wet to dry has zero role almost nowadays in the treatment of those physicians and those patients. The second myth, I can manage all ulcers. Nobody can manage all ulcers. You have to refer to a specialist at one stage. And no physician specialist in wound therapy can treat everything, even if they are certified wound. All care can be done in an outpatient setting. That is another myth. Sometimes you have to admit the patient and deal with the early stages or acute stages or difficult stages, then discharge them outpatient. Another myth, I don't have to get wound education or certification. It is like saying I want to be a vascular surgeon or a venous surgeon without getting certification or education in venous. The fact you are a surgeon or a physician doesn't mean you are a good surgeon, a good wound specialist. You need to get certified. Remember, the patients are older, multiple medical problems, non-ambulatory, need a caregiver, hospitalized and discharged. They need nursing homes, need home health, and lives alone. In the United States, many of them live alone, sometimes with a dog or cat, but they are not going to be served by them. So you need to look at all these as a wound champion. Again, wound care, multidisciplinary, multiple location. This is the fourth principle and strategy. You need to follow the patients in the different locations. And those locations is proven over and over by multiple publications that will help the healing. It can be home, nursing home, or a hospital. And we talked about already. The challenge is that it is so difficult to standardize the treatment because of different specialists, multidisciplinary, lack integration. No one specific wound care and vascular unit can help to treat those patients alone. You need to work with others. The principle of multi-specialty or disciplinary limb salvage is easy to understand, but you need different specialists to do that. Vascular surgeon is very important. Plastic surgeon, sometimes podiatrist, orthopedic surgeon, and nursing care. Designated service champions are a must. You need to transcend being alone to being transdisciplinary. That's very important. define your goals. This is the last strategy. Define the team, define the roles, decide who is the driver, and then this is how complex really is wound care. This is the way it is in our wound care. From the minute the patient enters the wound center or the hospital until they discharge. This is how many people are involved in it. Technology is there to help you, but it's very expensive. Limb salvage is very important, but it needs multiple systems and multiple teams. Patient-centered, it means don't send the patient to all specialists. Let the specialist go to the patient in one area. That will help the healing, decrease the non-convenience. Protocol-driven, another strategy. So in conclusion, optimal wound care is a team process championed by a physician or physicians of any specialty, but executed through multiple disciplines, protocol-driven, patient-centered, coordinated at different stages. And thank you very much for the chance, and I wish you a very good conference.
Thank you very much, dear friend, Professor Dr. Munir Nazal, for a great overview on the wound management. And would like to ask you a question before opening the floor for discussion. How frequent you face a patient with a foot ulcer or a foot wound with everything like the tissue perfusion, no infection, well perfused leg with no infection, and also
a specialist for wounds. You are a wound specialist, period. I see wounds from the arm down to the toe. So when it comes to the legs, 10% need revascularization. Specifically, most of them are diabetic patients. But many of the other patients like venous ulcers or radiation, they don't need revascularization, hardly they need any. But this is where the distal occlusive disease like in the toes or in the foot, because we do angiogram in many of them as a last ditch to see what's going on after an ultrasound, and they are beyond revascularization sometimes. And in this case, we use hyperbaric oxygen.
The floor is open for discussion. Dr. Nader.
Thank you very much, Dr. Munir. I just have one question. Actually, we see a lot of advancements as regards the flaps, the grafts, the different kind of dressings and the maggot therapy, VAC dressing. There are multiple and hundreds of things. But I think actually what we lack is a real life scenario algorithm. To when should we give up? Because no one actually is giving us the experience about the ugly side of the story, when the patient will need an amputation, or if there is an algorithm that actually this patient actually, as regard the cost benefit, as regard exposing him to extensive surgeries, that he will not really get benefit according to a specific criteria, and then it will be in his best interest just to proceed for primary amputation or not.
So I can tell you there are actually guidelines, algorithms, and sometimes the amputation, we call it primary amputation, is the treatment. Sometimes that's the best treatment. Like somebody comes with advanced, for example, toe or a gangrene